Good afternoon, my name is John O'Brien. I will be speaking to you for a few minutes about the problem of sleep and sleep apnea. Sleep obviously means to sleep and apnea means to stop breathing. Additionally, sleep apnea is divided into central, obstructive, mixed, and a condition known as the upper airways resistance syndrome, which I will not deal with. Central sleep apnea is where the respiratory center in the brain becomes lazy and forgets to tell you to breathe. In adults, in its pure form, this is very uncommon. The most common that we are going to deal with is obstructive sleep apnea, and mixed sleep apnea usually occurs in patients with obstructive sleep apnea who develop a central component. Obstructive sleep apnea is defined as a clinical syndrome marked by recurring episodes of upper airways obstruction that lead to markedly reduced hypopnea or absent apnea airflow at the nose or mouth. Looking at this diagram, you will see air flowing down the back of the nasopharynx into the trachea. When one falls asleep, the base of the tongue here tends to fall backwards and the soft palate tends to fall backwards. This causes either a partial or a complete blockage to airflow. The body can't allow that to continue, so after a while the patient with obstructive sleep apnea will cough and splutter and roll over and start breathing again. Sleep apnea occurs in up to 9% of males and 4% of females. And factors that predispose to it include age. It becomes worse as we grow older. The major risk factor is obesity, particularly around the neck and upper body. And obviously there is more to it than just weight. Genetics must play a part in terms of innervation of the upper airways and respiratory drive. The way you are built is also important. If you look at the back of the soft palate, some people will have a large area at the back, others will have progressive narrowing, and this is classified, and this is what we call a restricted posterior palate, and these people are much more likely to block up their airway when they fall asleep. So what? Apart from the associated snoring, which may bother the partner, it is a serious medical problem and is a risk factor for high blood pressure, heart problems, development of right-sided heart failure, and aggravating conditions such as cardiomyopathy and congestive cardiac failure. It presents with snoring. The major presentation that patients have is of daytime somnolence, but it can present with conditions such as stroke, poor concentration, impotence, and elevated erythrocyte count or polycythemia. So if sleepiness is one of the major presenting complaints, how do we establish whether a person is sleepy? One of the easiest screening tests is the Epworth Sleepiness Scale, which asks a number of questions and is designed to separate people who are what we call simple snorers from those who have sleep apnea. And questions are scored according to how likely a person would be to doze off in situations such as sitting and reading, watching TV, lying down to rest. And this is an easily administered test which gives an assessment of sleepiness. As a consequence of the excessive sleepiness, there are motor vehicle crashes, work-related accidents, impaired school or work performance. And this slide shows from an old study that when you compare patients with sleep apnea and controls, they have a much higher incidence of accident rates, accidents at which they were at fault, and times when they were cited for their traffic behavior. So how do we diagnose it? It's based on a high clinical suspicion, confirmed on what we call a sleep study or polysomnography, which measures flow of air, it measures the movement of the chest, it measures the sleep staging, it measures oxygen saturation, and graphs such as this are produced, and you'll see when you look at airflow here, the airflow stops, when the chest is still moving. That is a typical trace of obstructive sleep apnea. And when the subject starts to breathe again, there's interference with the EEG and interference with sleep, with the consequent lack of quality sleep. Limited studies can be performed with less sophisticated machines which are good for screening. Treatment is based on the severity of the condition And the standard treatment is to advise people to lose weight and exercise, control upper airways allergy, reduce things that will aggravate the sleep apnea, such as alcohol and smoking. But from a medical point of view, this gold standard of treatment is continuous positive airway pressure, or CPAP, which is administered by a mask, which is connected to a machine next to the bed, which sends a pressure of air down the back of the throat and keeps the throat open, and works as what's called a pneumatic splint. Buccal devices which fit into the mouth and stop the jaw falling backward can be useful. And does it improve the patient if you treat them? The answer is definitely yes. And in terms of assessing risk of these patients, one has to look at what severity sleep apnea they have, but perhaps more importantly whether they are adherent to their treatment. And these days the CPAP machines will give you downloads of the adherence, and this can make a significant difference to your risk assessment as to the effects of sleep apnea, because the treatment does work.